Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about gigantism and acromegaly, which are two disorders associated with excess growth hormone. So before we dive into these disorders, let's first talk about the growth hormone pathway. And zooming in down here on your slide, you can see that growth hormone, as we know, is going to be regulated by growth hormone releasing hormone. Growth hormone releasing hormone comes from the hypothalamus. It travels down through the portal system to reach our anterior pituitary. Our anterior pituitary is going to release growth hormone. Growth hormone then travels to several different organs, including the liver, where it is going to stimulate the release of IGF-1. Insulin-like growth factor 1 then travels to all of our different cells, our bone, muscle, nerves, and immune cells, and stimulates growth in these tissues. Additionally, it stimulates our adipose cells to break down stored fat, fueling the effects of growth. Additionally, growth hormone in the liver is going to stimulate the breakdown of glycogen. So one effect of growth hormone is the release of all this energy so that we can use it as building blocks to build more tissues. So think about releasing fats and releasing glucose when we're talking about the effects of growth hormone. Now, growth hormone is also going to be controlled through negative feedback. So when we have high levels of IGF-1, IGF-1 is going to travel back to the hypothalamus, and it's actually going to promote the release of growth hormone inhibiting hormone. Growth hormone inhibiting hormone is exactly what it sounds like. It is going to inhibit growth hormone release, and that is going to shut off this whole system. Now, moving back to the pathology of excess growth hormone is usually caused most frequently by a benign pituitary adenoma. So this is going to be a benign mass in your pituitary. You can see over here in this image on your right that we have a mass right where our pituitary should be. And one of the things this mass might be secreting is growth hormone. So this is going to in turn lead to increased IGF-1 release and excess growth. Now, there are a couple other things that can also cause excess growth hormone release. One would be your MEN1 syndrome. So your MEN1 syndrome is going to be a multiple endocrine neoplasia, and one of these neoplasias might secrete growth hormone. Additionally, McCune-Albright syndrome. So think of that syndrome that's presenting with precocious puberty and then some of those cafe au lait spots. Another thing it can present with is excess growth hormone. Familial isolated pituitary adenomas, so just these pituitary adenomas that run in families, can also sometimes secrete growth hormone. And then finally, this GNAS. GNAS is an oncogene that has been found in about 30 to 40% of the sporadic growth hormone secreting pituitary adenomas. So this is a mutation to look out for with association with these growth hormone secreting adenomas. Now, if we have excess growth hormone in secretion, it can lead to two different disorders. And the thing that separates these disorders is when this excess growth hormone occurs. So in gigantism, which is the first of these disorders we'll talk about, the excess growth hormone is going to be secreted before the fusion of the epiphyseal plates. And remember, at the epiphyseal plate, that's where a lot of the growth of our long bones occur. So before the fusion of our epiphyseal plate, that's going to be occurring in childhood before we are reaching our full stature and those epiphyseal plates fuse and stop growing. If we do have excess growth hormone in childhood before the epiphyseal plates have fused, this will lead to increased linear bone growth, and you'll get a person with an incredibly tall stature, a incredibly large person, perhaps the most famous of which is going to be Andrei Rosimov, or Andre the Giant as he was known in world wrestling. On your right here, you can see that he is incredibly tall. Use this picture to remember that people who have gigantism, when they have this growth hormone before the fusion of the epiphyseal plates, have this increased stature, whereas by contrast, people who have acromegaly, the difference here is that growth hormone release is occurring after the skeletal epiphyseal plates have closed, and this will lead to disproportionate growth. That's because your long bones are no longer lengthening, so you're just going to get bone growth in odd directions, and it's going to lead to this disproportionate bone growth. One final disorder I want to make sure I mention in this video is pseudoacromegaly. So pseudoacromegaly is going to be a little bit different in that it's not necessarily a tumor or something secreting excess growth hormone, but it's most frequently caused by medication-induced insulin resistance. So growth hormone and insulin are kind of opposites. They're kind of antagonistic of each other. And when we have medication-induced insulin resistance, it kind of lets growth hormone just take the right of way and exert its effects uninhibited in the body. So things that can cause this medication-induced insulin resistance and lead to pseudoacromegaly are going to be things like minoxidil or phenytoin. Primary hypothyroidism may also lead to a type of insulin resistance that can in turn cause some symptoms of acromegaly. But we call it a pseudoacromegaly because the levels of growth hormone aren't necessarily going to be higher. So those are our 3 different pathologies we'll be focusing on in this video. To distinguish them on presentation, think about gigantism with our increased stature, like we talked about, Andrei Rosimov. Additionally, heart failure is going to be the most common cause of death with these patients. That's actually what Andrei Rosimov died of. He died of congestive heart failure at the age of 46, so really, really young for congestive heart failure, and that's going to be a key association you might get tested on step 1. Acromegaly, by contrast, is going to present a little bit differently. Because it occurs in adulthood after those epithelial plates have already fused, we are going to see this disproportionate growth of your skeleton, your tissues, of your organs, and it's going to present with things like frontal bossing, so a more prominent forehead kind of pouching out here. This can lead to things like increased hat size or headaches in the morning. Jaw enlargement also occurs, and with this jaw enlargement, you might see a prominent jaw, so kind of protruding forwards, as well as spaces between the teeth as the jaw gets wider but the teeth do not grow, so you can see some gap tooth smiles here. Large hands and feet, so if you have large hands and feet, oftentimes patients will go up a shoe size and in adulthood, which is pretty abnormal. And then additionally, because you may have this disproportionate growth, this can actually lead to carpal tunnel syndrome, because as you're growing up, this growth is not proportionate and you're having this growth of your bones that can compress the median nerve that is running right through the carpal tunnel, because that area that the nerve runs in between your bones is getting much smaller, much more constricted, and that's why these patients might present with wrist pain or symptoms consistent with carpal tunnel syndrome. It also can lead to muscle weakness, hypertension, coarse facies, a deep voice or diaphoresis, and then finally, an increased risk of colorectal polyps or colon cancer. And that's going to be an important association to be aware of as well. So how are we going to distinguish between and diagnose each of these disorders? Well, the first thing that we're going to want to do is measure an IGF-1 level. IGF-1 is going to be elevated in both acromegaly and in gigantism. And that's because IGF-1 is going to be a downstream product of that growth hormone pathway that we just showed you. So if we have more growth hormone, it's going to stimulate more release of IGF-1. Additionally, we're going to have hyperglycemia. Remember when I talked about how growth hormone and insulin are kind of antagonistic here? So if we have excess growth hormone and insulin isn't able to do its job and pull all of that glucose into cells, it's going to build up and lead to hyperglycemia, increased glucose in the blood, and that's where that comes from as well. So these are 2 good diagnostic indicators that mean you should be kind of concerned for acromegaly or gigantism. A good test for these is then going to be a glucose challenge. So normally when you administer glucose, this should suppress your growth hormone levels. However, in patients with acromegaly or gigantism, the growth hormone levels will remain high, so this suppression test fails, and that's going to be a good clue that there's something wrong with your growth hormone axis. Additionally, if their gigantism or acromegaly is caused by a benign pituitary adenoma, you might be able to see it on imaging. Over here, you can see that we have this pituitary mass. If you have enlargement of this pituitary mass right below your optic chiasm, this can lead to compression of the optic chiasm, in turn causing bitemporal hemianopia. So that means that you're going to lose your peripheral vision on either side, and that is going to be one of the symptoms of having this pituitary mass, in addition to things like headache. If the heart is affected, you might see cardiomegaly on chest x-ray, and then particularly in acromegaly, you might see an old photo that doesn't look like the same person. So the classic one is on the driver's license photo, it doesn't look like the person that's sitting right in front of you, and that's because we talked about this disproportionate bone growth, especially in the face. It can actually cause a different facial structure and make it look like a different person. So that's going to be a consistent presentation with acromegaly. Pseudoacromegaly is a little bit different than the other 2 in that there will not be any change in the growth hormone or IGF-1 axis. If you administer a glucose challenge, for example, your growth hormone levels should still be suppressed, and IGF-1 additionally is still exerting negative feedback. So after we've diagnosed gigantism and acromegaly, how are we going to treat it? Well, the first thing we're going to do is resect a pituitary adenoma if it's present. Additionally, there's a couple drugs that we can use to treat these conditions. Ticagrelor, first of all, is a somatostatin analog. I like to remember somatostatin as somatostopin because it's stopping whatever it's acting on. In this case, it is stopping the release of growth hormone. And that's going to be incredibly helpful, right? If the problem is that we have too much growth hormone, then somatostatin stops the release of growth hormone, treating the underlying condition. Pegvisomant can also be used to treat these patients. It works a little bit different. It's a growth hormone receptor antagonist. So it's not going to prevent growth hormone from being released, but it will go and fight growth hormone at the receptor to ensure it can't exert as much of an effect. And then we have finally cabergoline, and cabergoline is a dopamine analog, so it does have some suppression effect on the release of growth hormone and can be useful to treat these disorders. So you made it to the end of this video, but what are some key takeaways that I want you to remember about gigantism and acromegaly? Well, I want you to distinguish these two by when they occur during a person's growth. So think about gigantism as occurring during childhood, leading to this really tall stature because the epiphyseal plates haven't fused yet, so we're getting growth of the long bones. And then also characterized by heart problems, and remember Andre the Giant, who died of heart failure at 46. Acromegaly, on the other hand, is going to occur when this patient is already an adult. So acromegaly occurs after the skeletal epiphyseal plates have closed, and that is why it leads to this disproportionate growth, meaning bony outcroppings on the face that make them look different on their driver's license photo, enlarging feet that make them have to buy new shoes, and then additionally, colorectal polyps and cancer are a key association with this pathology as well. For a diagnosis, a glucose challenge is a great place to start. It should usually suppress growth hormone levels. If it doesn't, it's a great indication that this axis is abnormal. And then treatment, if it's a pituitary adenoma, we're going to resect it. If we can't do surgical management, then we'll use medical management, either octreotide, pegvisomant, or cabergoline. All of these drugs either are responsible for suppressing the release of growth hormone or inhibiting its effects. Okay, so that's a lot of information, but how would they test you on this on a board style question? Well, something they might ask you is something like, a 45-year-old man presents due to noticing that his hats and shoes no longer fit. You ask to see his driver's license photo, and the photo appears to be of someone other than the patient. To treat this condition, the physician prescribes a drug also used to treat bleeding esophageal varices. Which drug was prescribed to this patient to treat his underlying condition? And listening to this stem, it really sounds like we have a patient with acromegaly, right? They have increasing hat size, increasing shoe size, the driver's license photo doesn't look the same. And then the question asks you, what drug could we give them to treat their condition that also treats bleeding esophageal varices? Well, any of these drugs down here could treat this condition, but octreotide is going to be the only one that is also used to treat bleeding esophageal varices, so that would be your answer in this case. Now that's all I have for you on gigantism and acromegaly. I hope this video was helpful, and I'll see you next time.